Go. Okay, great. Welcome everybody to the IHPI seminar series today. I'm Sarah Hallie, and I'm really thrilled to have our two guests today presenting about caring for the critically ill during the first wave of COVID and their experiences. The timing is really bittersweet for that. So I know there's going to be a lot of interest in having conversations with Dr. Iwashyna and Dr. Hallie Prescott, both of whom are faculty in the Department of Pulmonary and Critical Care Medicine here at University of Michigan and in the VA, and have been part of the COVID pandemic and caring for patients in the VA and the ICU, as I think a lot of us know and have heard from both of them throughout kind of the initial wave to now. They've been doing work in the area of clinical care, research, and policy. And those are the three buckets of work that the talk is going to be divided into today. So what we're going to do is let them go ahead and begin. I will be monitoring the chat. I have a few questions that came in ahead of time, so I'll be sharing those as well, but I'll be monitoring the chat for questions. We'll pause after each of those kind of groups of clinical research and policy for conversation with our two guests. And we're thrilled to have them and to have this opportunity to talk with all of us about this important issue today. So with that, I'm going to turn it over to Dr. Iwashyna and Dr. Prescott. Thank you so much, Jack and Hallie.
Thanks,
Sarah. Great. Thanks for the introduction. I'm going to put up a slide. We don't have many slides, but we thought we'd give you a little bit of something to kind of look at as we start this conversation. So I'm going to start it off asking Jack about what those very first days and week looked like. Jack was in the VA ICU when we got our very first cases in Michigan, and we had to rapidly activate a COVID ICU. So Jack, tell us about that, what you were feeling, what it was like to be there.
So it was awful, right? So I feel like everybody who's a hospitalist or a critical care doc was sort of pacing the floor for the last week beforehand. And we were all reading up on SARS-1 from Toronto, which was not making us happy. And trying to figure out what we could do to prepare while we just sat around waiting. Honestly, which is not that dissimilar from the feeling I'm having this week as well. Right, when we came up with a name for this, we were hopeful that we were just being unduly pessimistic. And what Hallie's shown up is the initial curve for what our spring looked like. And in the bottom corner there is the hospitalization curve for Michigan as of a week ago. And as you can see, we are just about at the same place we were last year. So I was supposed to be just covering, right? A colleague of ours, his wife had gone to Ohio for a college visit and had come back with a flu-like illness. And so just out of an abundance of caution, he was quarantining and I just came in for the Saturday, Sunday for the weekend to let him be home. And around in the morning, it was boring. And in the afternoon, they said, hey, one of our first confirmed COVID patients, a veteran, about 35 years old, is coming back in because his wife says he can't breathe, and apparently his pulse oximeter is reading in the 70s. And so we brought him in, and at the same time that we were trying to get him tucked away, we had environmental services was there with a bright red masking tape and to put up plastic sheets to try to create an isolation unit because we didn't know how many were coming. And then it basically just came. And the next day there were two more. And then the next day there were two more. And then there were a few more. For me, I think the most striking thing about that period was wondering if this was SARS, right? And so ICU docs remember SARS, that 53% of all the deaths in Toronto in 2003 were hospital acquired. A huge number of those were among physicians and nurses. And so our best guess was this was the same virus or something pretty similar. So I moved into the basement like a lot of people did because I was lucky enough to have that extra room. And basically I remember my kid coming down and plopping on the couch and me like having this horrifying scream at Jacob about to like, just get out, like get out. Because I was worried I was gonna kill him, right? It's part of why I shaved my head was so I could just take dial soap to my head at the end of the day. And so the first weeks were a combination of just this incredible teamwork where, environmental services was going around with Virex and Clorox and cleaning everything. And we didn't really know what the hell we were doing or how sick they were and just trying to to figure out how to establish some baseline. But while I was upstairs, Hallie, you were also pretty quickly downstairs trying to provide care to all the other veterans who were still sick and needed care, as well as non-veterans, in a world that it also, I know we both found really challenging because we had to exclude families from the hospital, and we both think of families as integral parts of the ICU team. What was that like?
Yeah, thanks. So, yeah, right. As Jack was kind of taking care of these very first COVID admissions, our normal ICU, which was on the 7th floor, converted into a fully COVID unit. And then obviously we had to have some place to take care of other critically ill patients. And so on the 5th floor, a new ICU was created. And so this was kind of amazing. I showed up to start working there a few days, I think, after this had been activated. And so there was, ICU nurses that had been sort of pulled up from the floor, people who had worked in the ICU, 5-10 years ago. Some of, people that I remembered working with as a fellow were now back working in this ICU. And likewise, we had respiratory therapists who had come in from sleep clinic. And so we really people were pulled from across really, I think, the VA organization to man this new ICU. And so there was certainly this kind of sense of, I think, being overwhelmed, right? I mean, a lot of people were practicing outside of their normal sort of day-to-day scope of business. And there was a lot of new faces. And I remember going around that very first day saying, "Oh, hi, I'm Hallie, I'm an attending coming on this week." And they'd say, "I work in sleep clinic normally." And I said, "Okay, very good. Well, thank you for being here. And, what's your name?" But a lot of times the very first way people introduced themselves that first few days was just, "I'm from here, I'm from somewhere else." And I think that was just sort of a testament to how, I think scared everybody was. Nobody sort of knew what to really expect, as Jack was mentioning. When I think back on those first few weeks, I think the thing that became really clear was just, it became very evident, like all the things that happen in our ICU that we sort of take for granted when you try to build a brand new ICU overnight. So there's a lot of really sort of hard teamwork that goes into caring for the ventilator, to sort of keeping patients comfortable, to keeping them awake, to keeping them moving as much as possible, despite being as sick as they are. And that became just incredibly much more difficult when we have a brand new ICU. And we were actually doing sort of charting on paper because there wasn't even time to train people in all the sort of typical ICU charting. So I just remember thinking back, wow, like this, it just really became clear to me just all the incredible sort of work that our teams do day to day in the ICU, and trying to recreate that overnight as a challenge. The other thing that was sort of really eye-opening was the absence of families. Yeah.
I just get tachycardic even remembering those first few weeks. Like I realized I've got a heart rate of 140 from remembering walking around on the 5th floor, and oh my God, I'm the only person who knows how to drive a vet here. Sorry, go on.
Yeah. So, families, I can still remember being a resident when we had visiting hours that were like 5 1-hour blocks, but for the vast majority of the day, families were not in the ICU. And that was like a transformation that I think has, taken over the US and also really around the world in the past 10 or so years, this kind of opening up the ICU to families, encouraging them to be at bedside, encouraging them to join our rounds. And that has become the sort of normal. And then all of a sudden that went away really overnight. And so again, you sort of realize like how much you came to appreciate having families there, and how much families are able to sort of like absorb. They don't maybe understand every single detail of what you're talking about on rounds, but they understand how hard you're working for their family. They sort of understand when you get into a rock and a hard place, oh, well, if we could do this, it would help the lungs, but it might hurt something else, and they sort of like are coming up to speed with all the things you're grappling with, even with sort of iPads and phone calls and all this kind of stuff that we did. It's hard to sort of replicate being there in person. We had one patient who had been in the ICU already for several months before this, the COVID pandemic happened. And so then he, moved down to this new ICU where we were housing non-COVID patients. And it was really challenging, sort of losing his family support, only being able to communicate on the, iPod or iPhone, but not, not being able to talk, being on a ventilator. And so this particular patient had a birthday, and he had not seen in person his family for about 6 weeks. And again, of course, we were, visitors were limited across the state and across the country due to infection control reasons. And so we weren't able to bring his family into the hospital. And so one of these pictures up here on the right is we decided that the sort of team came together, the residents and the nurses and the respiratory therapists, and said, hey, he's doing better. Like, we can't bring his family in here, but it's a really nice day out. I wonder if we might be able to bring him outside. And so we took him on a road trip, and he didn't know what was happening. We just said, we're going to get some fresh air, and he was looking forward to that. And so we took him out to the very front of the VA, where there's kind of a long driveway that comes up, and there's the circle out front. And we had told his wife. And so she, turns in to the driveway with this minivan, and our patient, you could just sort of see he was like blinking, like he thought I think was imagining this, like, that can't be, there's no way. And she pulls up and like hops out in mask, and he was in masks, and everyone's in masks. But she came and she saw him, and we all just burst out and sang happy birthday. And I thought that was just, it was like a super special moment to be able to do that for the patient. It was amazing for him, I think, for his family, but it was also amazing for our team, because this was about 6 weeks into this ICU, and sort of seeing our team grow from these people really who had never sort of worked together, or at least not on the same unit, to come together to sort of say, hey, we're going to do this for the patient, and to sort of pull it off and make it happen, was really uplifting. And there was just this kind of like cheerful mood on the 5 North ICU for the whole rest of that day, that like, we did it. We did this really awesome thing for this patient. And that was, I think, one of my fondest memories of those weeks in that ICU.
And frankly, on as a group, we have basically VA critical care group text for solving each other. And there was just days of like, can you believe Hallie did this? This is the coolest damn thing we've done. We work with the best team ever. I think the other thing that sort of, right, around 6 weeks, we all kind of figured out we weren't going to die of this thing, that it was a serious component, but it wasn't SARS. And so it was part of that first month of really vigorous effort where we changed a lot of the way we had to think about infection control.
Yeah. Yeah, Jack, why don't you talk about the heated high flow? Because that was something that there was a lot of fear in the beginning about, can we use heated high flow? Do we have to really do things differently? So, and you were on the unit during those first days when we were grappling. So talk about that work.
Yeah, so right, there was one mediocre letter in Lancet Respiratory Medicine, and God, I hope none of the editors are on the call right now, or I'm never getting published in Lancet Respiratory Medicine again, which I really do love as a journal. It's a great journal. That said, like, we were worried that heated high flow might aerosolize these things. So therefore, a number of groups had started intubating people at what technically is 6 liters per minute, which, let me tell you, is a whiff of oxygen. And so we were,
from an ICU doctor perspective only.
Yes, from an ICU. So we were having to intubate people, and intubation's a non-trivial procedure, right? It's a big deal. The entire anesthesia exists to intubate people. They're not the only people who can intubate people, in case there are any VA folks listening. And we were doing it, and it was rough, right? Like, we were doing risky procedures on people earlier than usual. And so pretty quickly we said, like, this just doesn't make sense. And so I basically asked Amy Cohn, who, if you guys don't know her, is in the School of Engineering, and Amy Cohn just solves shit. She just solves problems wherever they are. And she pulled together a team that said, so here are 2 things. The first thing is, show me how this thing works, and let's see if we can build some kind of complicated mask that's going to go over folks. But the second thing we should say, are you sure that this thing actually aerosolizes more? Because it seems like the data that you've got are just from one dummy, like literally a plastic mannequin. And so there's this wonderful team that pulled together over about 3 weeks, and I was on service. So I just send occasional emails, but Hallie stepped forward, Dina Costa from the School of Nursing, Amy from the School of Engineering, some folks from the medical school, and got into the sim lab. And what you see up there is basically they got detectors from our auto engineering group, who it turns out are the best in the world at detecting the amount of particulate that a car puts out, which is, on the whole, much less than a coughing human being puts out. So they had very sensitive indicators, and they could measure how much particulate i.e. potential viruses, people were kicking out on this high flow nasal cannula, and they showed that it was safe. And so honestly, they ran a bunch of patients, and I've never before sort of written up a paper and had policy change that afternoon. And we instantaneously at both the U and the VA, as a result of this VA-initiated quality improvement project, said, no, we're going back to using heated high flow nasal cannula the way that we always have to provide superb care to patients. The U changed the practice. I know Penn changed their practice as a result of this paper. I kept getting emails from folks saying, when we released it on medRxiv, saying, this is great. Our infection control people reviewed it and agree. Just to be clear, you're using high flow now? And I said, yes, we're using high flow now. And they said, thank God we can stop tubing all these people unnecessarily. And it was just the kind of thing about the U of M, right? That you could happen to know the person who knows the smog engineers who have the detector that you could use. So while we were doing this, you of course were also trying to spin up a clinic experience that more or less overnight went from seeing coughing patients in person to seeing them online. What was that like?
Yeah, so that was very interesting. I had, really not done telemedicine since I was a resident, but the VA, of course, has lots of infrastructure in place to do this. So basically overnight, we all got our, TMS modules completed. This headset came to me courtesy of the VA, and it was like all of our patients overnight converted to either video or phone. So throughout those weeks on that 5 North ICU, yeah, I was also sort of seeing all of these patients. A couple of them I said, it's probably really important to see you in person. I'll, push you back 3 months for when this is over. And then of course, June rolled around and I thought really was not that smart to think that this would all be over right now. Fortunately, I was glad that most of the patients, yeah, we were able to sort of still see virtually. Because yeah, when June rolled around, we realized that we still had a long way to go before this was over.
And the striking thing about that is particularly it was how fast the VA as a system just said, yep, we're doing this by Monday.
Yeah.
And there was essentially no furloughing of patients. There were no canceled clinics. They were just en
Just
masse.
converted, en masse converted. Yeah.
I'm sure some of our ambulatory care colleagues on the phone could tell long, long stories about that. Dr. Hallie, do we want to open up for questions for a minute or two about early clinical experience?
Yeah, folks, why don't you type in any questions you have sort of in the bucket of clinical experiences. I'll start with one that came in ahead of time, which speaks to what you both were talking about already. What practices or behaviors have you found provided the most comfort and support to families, especially during the restrictions? Anything?
Yeah, I mean, I think that we made a very conscious effort to do telephone calls with every single family every single day. And when possible, we did video conference calls. And I do think that, helped a lot. Again, I think it's really impossible to replace being in person, but we were doing everything we can. And, the VA opened to non-veteran patients during that time as part of the VA's 4th mission, which was also, I think, a really special thing about that time. And so I had several patients in this ICU that had been transferred from other hospitals. And of course, everybody was really feeling overwhelmed at that time. But we had patients that were transferred in, who'd been on a ventilator for, 7, 8 days. And when we called the family when they arrived at our hospital to give them an update, there was times when they were like, what, they were on a ventilator? And so I think it was really clear just A, how overwhelmed everyone was, B, how hard it is to keep families updated. And they were just so incredibly grateful, I think, to be getting those sort of, at least daily updates from family.
Yeah, I mean,
from us, yeah.
I think the other thing that we all did as attendings was step forward into that and say that is a core responsibility that often we let house staff do a lot of family conversations. And because there was less opportunity to sort of do low grade surveillance, I think all of us were spending about 4 hours on the phone, right? About a half hour per patient for each of 8 really, really sick patients. Every day as a core component of what we did. And I mean, I spent a lot of time gowned up in full isolation gear, holding a phone over a patient who we'd coordinated a spontaneous awakening trial so that their kids could sort of see them smile at each other and see them blink. It was something that I think, for me, Mike Mendez really said, this is something we're doing. and made a point of excellence for our group and a lot of pride. And then a number of people, palliative care from our third day, stepped up and was actually joining us on rounds so that they could call and do updates for families too. Talk.
I think by having the team, like these families were able to get multiple updates a day because it would be the attending and the residents and palliative care and the bedside nurse. And so, between having all of those different people kind of helping out, we were able to provide updates often several times a day.
And with the fourth mission, there were people coming into the VA who weren't veterans and didn't know that the VA provides absolutely superb care. And so we had to do a lot of work to help them understand that that their patient and their loved one was getting better care than they would get anywhere else in the world. And frankly, afterwards, our numbers showed it. We provided spectacular care to these people.
Yeah. We had a few people transferred in who were on ventilators and sedated. And so when they woke up and, I always go in and say, hi, I'm Dr. Prescott, you're at the Ann Arbor VA. And the patients were like, no, I'm not a veteran. I don't know what you're talking about. So it took a lot of explaining. I mean, there were people who I think had gotten sick right around the time the pandemic hit and the world had really changed when they woke up.
Yeah.
Gail, I think we have a question from Gail. Gail,
how will these political experiences?
Okay, go ahead, Jack.
How will these inform our future clinical practice in the post-COVID world? Oh, Gail,
that's a big one.
I'll give a quick answer for my clinic where I think about this a lot. I've got a ton of patients who are snowbirds. I used to do all this careful scheduling. Oh, I'll see you right before you go to Florida, then right after. And now I'm like, you know what? I can see you anywhere. And so I'm doing a lot of kind of alternating face-to-face and video visits. And it just sort of adds a whole lot of flexibility. So I do think that's one thing that will stay. Gosh, in the ICU, I do miss having the families be there in person.
Yeah, I mean, so I feel like the other thing that we learned, and this kind of pivots us towards the next component, is we had an incredibly generative, from a research perspective, last 8 months, because there were a whole lot of questions. And the New York Times charitably paraphrased Obama's foreign policy as "don't do stupid stuff." That I feel like was the biggest. A lot of people were hurt and killed over the first few months, where people decided COVID meant we could forget every other kind of research that we'd ever done. And we at the Ann Arbor VA were not that people. We decided that this was sepsis and ARDS. And unless we had compelling evidence, we were going to stick to good practice of sepsis and ARDS. And remembering that there are far more ways to be wrong than there are to be right. I think that conservatism, plus a really aggressive focus on innovating in order to provide the fundamentals well, reinforced my strong priors that stick to the data and perform everyday care superbly, brilliantly. Should we move to the research surge?
Sure.
Part?
Yeah.
Excellent. I'll bring up our next slide. So, Jack, you I think referenced the Dirty Dozen. These are they got an image up here describing them. But tell us about your work with the Dirty Dozen and how you were able to sort of share this during the onset of the pandemic.
Yeah, so one of the things we saw very quickly was that people were surging into roles that they'd never been in before. And frankly, a lot of people were overworked and mistakes were being made. And in some cases, we saw those because as a part of the fourth mission, what we were doing was accepting patients who were not getting better at other facilities, in part because they were being cared for by folks who hadn't done inpatient care in 30 years. And so a group of us, including Hallie, Jake McSparron, colleagues from Mayo, colleagues from Vanderbilt, colleagues from Glasgow Royal Infirmary got together and said, look, if you had to summarize everything we know about what can go wrong in ICU discharge, what are the 12 things you do? And put together a list of kind of 12 practices to try to really reinforce, here are the boxes to check to make sure you don't cause preventable harm. And a lot of it was just reinforcing good standard practice, but reminding folks about these implicit practices that usually well-functioning systems are able to sweep up, but because there was so much surge pressure, they weren't. And then we discovered Zoom. right? And we discovered it turns out you can give a talk in England at 4 in the afternoon and at Norway in 6 in the afternoon and do that all very conveniently. And so a number of us, but I had a lot of the privilege of doing this. I gave probably 15 or 20 versions of this talk over the next 2 months around the world, starting with VA and Arbor and the U of M hospitalists and then U of M internal medicine rounds to just say, here are the fundamentals to go through. And people found this a really useful way to organize there. Well, at the same time, I was working with mentees like Ryan Barbaro to show that, like, it turns out ECMO works for COVID. And again, this a lot of work being done to say, like, what are the fundamentals and do they work in COVID? And if they do, how do we focus on delivering them? And at the same time, Hallie, you were doing a lot of work asking, how can we support the state of Michigan more generally in understanding what are the fundamentals for COVID and how those outcomes are? What was that project?
Yeah, so I am fortunate to be the sepsis lead for the Hospital Medicine Safety CQI, and this is a new initiative for the HMS CQI that had just started in January 2020. And so we were really like early days in sort of getting this work off the ground. And then all of a sudden, a lot of our meetings were canceled, paused. We were all being pulled into clinical service. And so we are pausing work on sepsis. And so I just one day was sort of reflecting on this. And it's like there is some serious irony to the fact that we're pausing, sepsis quality improvement work as people around the world are being hospitalized and dying from viral sepsis. And so, I reached out to Scott Flanders and Elizabeth McLaughlin, the PI and project manager for HMS, and I said, hey, what do you think about us doing something about COVID? And they took about split second and said, absolutely, we should totally do this. And so very quickly, really a testament, I think, to the infrastructure of these CQIs, the support from Blue Cross Blue Shield of Michigan and the sort of long institutional history at University of Michigan, really within 10 days, we were able to pool together many different CQIs and launch an initiative and a data collection called My COVID-19, where we were collecting data in the height of it across 38 different hospitals in the state of Michigan about patients hospitalized with COVID-19. And this work was really cool, I think, because a lot of the surgeries, of course, were being paused. And so a lot of the CQIs focus on surgical or procedural care. And so they didn't really have a lot of work that was being done because they weren't having cases. And so a lot of people who work on different CQIs and abstract for surgical cases actually participated and joined in this My COVID-19 registry. And that was, I think, that was very cool. And so in total, we've collected data about around 3,000 hospitalizations for COVID-19 across the state. And in addition to doing this kind of detailed collection of data during the hospitalization, we're also the abstractors at each of the local hospitals call the patients at 60 days post-discharge. And we ask like a sort of a standardized battery of questions about ongoing symptoms and essentially what is life like after COVID. And so we just had our first paper about these longer term outcomes published in Annals of Internal Medicine this past week, which has gotten a lot of sort of attention. And the main, I think, take home messages were that there are a lot of struggles that our patients have. So we in total got in touch with about 500 patients after hospitalization, and 40% of them said, yeah, we are still not back to our normal activities. Of those previously working, 40% still not back to work. 1 in 10 said they had used up essentially all or nearly all of their life savings as a result of their COVID hospitalization. I mean, these are huge impacts. And so I think this work has been really important. There's been a lot of, I think, sort of anecdotal reports of these things, but I think this provides a little bit more in terms of numbers and how common these issues are. And then when we just count hospitalizations or count deaths, we are underestimating the burden, which I think is particularly important now as we have COVID fatigue and people saying, oh, most people do fine, they survive. Well, it's not just dying and surviving. There's a lot of people who struggle for a long time after their COVID hospitalization. And so we continue to do, more work, particularly now as we're, heading into this, next surge.
I think one of, the other components that you guys discovered pretty early was that, I think there was some hope, and if I'm talking out of school, just wave me off here, that there might be one easy trick that if we could just get folks to do?
Well, I don't know that that was a learning of the My COVID-19 registry so much as what the world has come to find. I mean, I think you're right. In the beginning, my sense from this pandemic is that people thought this was something totally new and might require a new paradigm or a new miracle drug, right? So there was like new lung injury phenotypes, and maybe there should be new ventilator management, and maybe there was going to be some new drug that really helped. And you know, we have steroids and they do help, but I do think that as time has gone by, we have come to realize that more than not, you know, severe COVID behaves like we've seen sepsis, like we've seen ARDS, and the things that have really improved outcomes in critically ill patients over the past decade have been really this like careful attention to these best supportive care practices that, you know, Jack, you were mentioning. This is, you know, getting people sort of awake on the ventilator, using lung protective ventilator settings, getting people off the ventilator as soon as possible, getting them up and moving again, sort of attending to all of their other sort of medical conditions that might be exacerbated over the course of this hospitalization. And so I think that now as we go into this third surge, I think that you know, the My COVID-19 registry, but also I think really across the US and the world, people have realized that, you know, it's not really fear of the unknown anymore, that we know how to take care of this. It's sort of having the sort of energy to sort of keep going now 10 months into this, when the adrenaline that we had early on is running out. How do we stay attentive to ensuring the very best practice, sort of like dotting the I's and crossing the T's every day in the ICU, at discharge, you know, making sure people get the follow-up after hospital discharge as well.
Yeah, and I feel like that's been as somebody who's a little more senior and so has done a lot of background work for that, that kind of trying to understand, is this something new or not? And the answer really being it's new in magnitude, but it's not that new a disease. And we know how to do this, and that there isn't going to be a silver bullet.
Yeah.
Right? I mean, yes, it would be lovely if remdesivir just suddenly made this stuff melt away. That has never been true for any viral illness, and it's still not true for any viral illness. Right?
Yeah.
It'd be great if, you know, you could ventilate these patients any which way, but you just can't.
Yeah. Well, and all the things that have really made the biggest difference in critical care over time have been these supportive care things that have never been for one very specific type of, you know, respiratory failure. It's been for hypoxic respiratory failure really across the board, and save things in terms of like our ventilator liberation strategies. Those are never really for anyone with one specific type of disease, but all types of sort of all comers with critical illness have benefited from those kind of strategies, and so do our patients with COVID.
Yeah, and neither of us, I think, would be in the least bit sad if there were a magic bullet, right? If there's a pill that somebody wants to discover that makes this go away, that'd be amazing. It just doesn't seem like that's going to happen.
I mean, I think the one thing, I mean, we have, you know, seen in the My COVID-19 registry, and, you know, other people have reported that, you know, from the United Kingdom, and I think, you know, Emory as well, that mortality in hospital has been going down over time. And, you know, I think that it's hard to sort of disentangle what are the main drivers of that, right? Is that because we aren't doing these crazy things like putting them on the ventilator after 6 liters anymore? We figured that wasn't the right thing to do after a week or two, or we've stopped giving them Plaquenil and all this other stuff we were paying attention to, and now we're focusing on these basics again. Or is it, you know, partially effective social distancing and masking such that their, you know, infectious dose is lower, or, you know, we're just more comfortable? I mean, I don't know, probably all of the above, but you know, it does seem that you know, our 60-day mortality has gone down over time across the state. And we hope that that continues even as our hospitals get more full going forward.
Yeah, and the question of how we support this during the increased load is going to be a challenge.
Yeah, right. Because part of it was like before we immediately filled all up and then we kind of trickled down. Now we're in this ramp up phase. And so will this, you know, like how much of this trend is related to just sort of overstressed systems and overfull ICUs? I don't know.
Yeah. So let me ask you, sorry, go.
I was just jumping in with a couple questions in the chat that are sort of in line with what you are both talking about.
Great, yeah.
But I don't want to interrupt you, Jack, if you were responding to that.
I was actually about to say, at some point I'll talk about some of the NIH stuff, which mostly exists to say, turns out that thing Hallie's already published. We've spent 7 months trying to get operational and now have operational from an NIH study, but to just speak to how incredibly nimble the My COVID group is. In the time that Hallie got 560-day follow-ups completed, written up, published, and analyzed, we've built a nationwide group to do something similar, and we have enrolled 17 patients. We have completed 17 of our 30-day follow-ups, and that's been under the most expedited NIH process I've ever seen. But let's answer Larry's question. So do we know the impact of patients with COVID who are not sick enough to be admitted? I think
So
no.
I think no, but I mean, I will say that there's been a lot of anecdotal reports, right? I mean, and I do think that there is credence to the sense that there are people who have sort of lasting challenges and have like sort of a slow recovery despite not needing to be in the hospital. And then in terms of the admission threshold changing over time, we've looked a bit at this. You know, it's interesting because we think a lot about these really severe hospitalizations and people, you know, in the ICU on mechanical ventilator, but in the My COVID-19 registry, about 30% of the hospitalizations never received any kind of supplemental oxygen. And then we sort of, when we look at the proportion of people by this WHO sort of illness severity category on day one of presentation to the hospital and how that has changed over time, it's actually been pretty stable. We don't have, you know, data yet to look at this sort of current surge that we're in, but at least things were fairly stable from March through like July or so. But I will be curious to see what goes, you know, what happens from here. Anecdotally, it seems that we have fewer people ending up on ventilator right now, and we're able to do more with heated high flow, which partially, you know, I think has to do more with increasing comfort over time.
And then Nicole Smith says, I work in the community health field. Did you encounter a lot of barriers to community health resources or high need for them, such as needing food, unable to get medicine, pay bills, the financial devastation of 2020 plus COVID?
Yeah, so we did see a lot of that in the 60-day telephone follow-ups that we had. I mean, there were people who reported, you know, food scarcity, you know, skipping medications due to not being able to afford them, and then really depletion of essentially any kind of savings that they had prior to their hospital. In terms of community health resources, I think that we are seeing that, and I think a lot of the, you know, that sort of coordinating that discharge care has gotten a lot harder due to infection control, I think, precautions in terms of people going to nursing facilities or getting home health care. We did ask people at the 60-day telephone follow-ups whether they had had any kind of primary care follow-up, and about half of them had follow-up within 2 weeks. But there was 1 in 5 patients who by day 60 had not had any follow-up, which seems, I mean, it seems really high to me. It feels like anybody who's hospitalized for COVID really should have follow-up within a month and definitely within 2 months. So I do think that, you know, suggests a room for improvement. We did see that the majority of those follow-ups were done by telehealth, I think phone and video. And as that, you know, as those sort of capacities build, you know, hopefully we'll be able to get to 100%. But I certainly think that's something to target going forward, is making sure that there is some follow-up after hospitalization.
Yeah, and we certainly know also that the informal caregiving components of this are so important. And between churches, parents, and spouses, the last year has made it vastly visible to me how important those are. You know, a group at ISR, the Institute for Social Research, has been doing a lot of interviews with patient caregiver dyads, and has coming out December 15th in the health system, basically a workbook for caregivers to help them understand how to get the information they need out of a hospital system where they're not going to, and then also how to help anticipate and navigate the transition challenges. Because trying to do this over the phone has made me very aware of just how much at the bedside folks were just picking up all kinds of information from our nursing colleagues that we weren't giving them credit for. And I think figuring out how we can support increasingly isolated community families and then also the churches that provide such a critical role for so many of our as basically a functioning social safety net, and also encouraging people who, as Professor Robinson in the School of Nursing says, even if you haven't been to church in a month of Sundays, they're still happy to have you back. So call them because they may well be able to help you get some lasagna. So Hallie, should we pivot to talk about some of the policy components we've been working on too?
Yeah, absolutely. So I think we can talk about some sort of local policy first. Again, during these kind of early days when things got crazy and we activated our ICUs at the VA, you were also working on the scarce resource allocation team. So why don't you talk about that experience?
Yeah, so one of the things that both the VA and the university said early on is, if we start running out of stuff, how are we going to deal with that in an ethical and responsible way? I should say clear for everyone here, at no point did the VA or the university hospitals, to the best of my knowledge, ration care. And everybody got full care. And actually, for the VA, where I physically was, I'm absolutely certain that was true. At the same time, I could say it's also become very clear from a lot of conversations that I'm not allowed to quote on the record that that was not true of all hospitals in the state. Several hospitals in the state, for example, shut down their ECMO programs, essentially because they couldn't staff them and didn't feel like the resource costs were that. The dedicating 3 nurses around the clock to an ECMO program made sense. And although that wasn't called rationing, boy, it sure looks like altered standards of care. And at VA and the U, we were well enough resourced and lucky enough in terms of our epidemiologic catchment that we didn't have to do that. So we set up a scarce resource allocation team. And part of what was fun was we spent a lot of time working with political scientists to ask, how do you build an institution that takes care of it? The phrase we were using was, ethical principles don't implement themselves. And so I reached out to Julia Lynch, who's a political scientist at Penn, and said, design me a system to make sure the physicians don't accidentally take over things and end up making decisions that would not be in through the interest of the veterans. And so she pulled together this whole kind of, basically wrote us a constitution that said, yeah, everybody agrees about sort of broadly utilitarian ethical principles. How do you actually implement that? And it designed a system to basically make sure there was joint decision-making between a non-physician, a non-clinician, a nurse, and a physician as tri-chairs, and then built a team and used ranked choice voting in order for us to be able to make sure we could help design principles. Originally, we thought that was going to be about scarce ventilator beds. Turned out it was about scarce ventilators. Turns out it was never about scarce ventilators. We started running out of getting scarce nursing, because it's always the nurses. It's not the machines. It's always the nurses, and running out of our dialysis stuff. At the same time, we also had to say, okay, this SRAP could help design kind of fair policy, but it's a really bad idea to have them also trying to implement it at the same time, because that's just a setup for moral conundrum. So there was a triage team that was set up that, because you're hearing that that the VA is sometimes a small place, and so people play multiple roles. So Hallie, you got called to run the triage team.
Yes.
What was that?
So I just remember, yeah, right, being like having sort of this like overwhelming anxiety when I was invited to participate on the triage team. But it, obviously this is a hugely important thing. And so I said yes. But I still remember like, yeah, just the kind of like overwhelming dread. I mean, you go into medicine to help people. This is not what you envisioned when you were a medical student, thinking about sort of rationing care in this kind of a way. But I think one of the important things that, I watched this actually, SCCM had a thing about these SRAD and triage teams, and Laura Evans said, the reason we do this is to try to save more patients, right? If we just let these things play out at random, you're going to be doing more harm. We're making the least bad of a very bad situation. And that really resonated with me about sort of just how important it was to not just like wait till you were truly like in the crisis situation to sort of sort out how you were going to like, give your last whatever it is to this patient or that. Like you need to decide that ahead of time so that you have time to vet those processes, that everybody agrees that this is the sort of fairest and best way, knowing that there'll be no perfect system. And so you sort of, I think, get over this like moral, like sort of hazard by carefully planning. So nobody wants to do this work, but it's so important to do. And so we, thought through, how do you actually calculate these SOFA scores that everybody agrees, yeah, you should use SOFA scores and, bucket people into triage categories. But there's some discretion, in terms of you have to estimate the mental status in somebody on sedation, right? So like, how do you do that in a fair way? And sort of like, who's collecting this data? How do you collect it? How do you get it to the right person to like, be able to make these decisions? So we spent a lot of time, doing that. And for actually some of the weeks in this ICU, I literally calculated the score on all my patients every day, which I actually found to be a fairly enlightening process. And in the end, we never had to enact these things, as Jack said, but it was sort of useful, I think, for my sort of mental processing to sort of, play out, well, who would be the patient that, would potentially be rationed of the unit that I'm on, and how would I think about having those conversations? I think that was the other really hardest thing, was how do you have those conversations,
Yeah, and I think
with families?
my sense is it also helped us learn what I've come to think of from Mauricio Ciccone in Lombardi as rule 0 of scarce resource allocation, which is remove the scarcity, right?
Yeah.
So that way too much of our scarce resource allocation, frankly, indulges in a little ethical superheroism of like, I, the grand ethicist, will come and tell you which of you should die. And honestly, as a clinician, doing those exercises every morning where we asked what could be scarce and how would we allocate it was extraordinarily useful in motivating us to say, like, let's fix this. How can we think much more creatively about making sure that we never have to do that? And we had pretty routinely, between the triage team and the SRAT, 40 people on calls at 7:45 every morning for about 3 months, getting together, asking what could we run out of and how do we fix that so we don't ever have to have that conversation? And we were able to not.
Yeah, I think there was a lot of like sort of things that were changed in the way pharmacy sort of like dispense medications, or sort of the protocol for running these things. Because I think medications was actually the place where we actually really felt it like impending, sort of shortage coming on. And I was super impressed, sort of like as the institution as a whole, to be able to sort of forecast, identify these things a week or 2 weeks out, and sort of make little tinkering changes where you aren't decreasing the quality of care, but you're still conserving what you have to be able to do the best that you can. So yeah, no, I thought the SRAT, did a great job of, like you say, rule 1, avoid the scarcity. That's where we all want to be. But the same thing, it's just like in the ICU, rule 1, it's like we're here in the ICU to save the patient, but we still want to have the goals of care conversation before the very last minute. So wow.
And just also, I mean, I think a lot of us had to learn about logistics and supply chains in a way that we had been actively avoiding. Again, Amy Cohn spending a ton of time upskilling a lot of physicians that like stuff doesn't just magically appear from China on your loading dock, but you need to think through these things, as well as like the Milo minder binders who work somewhere in the basement of the VA who would just like show up with trucks loads of stuff and like, I don't know how we have enough PPE, but we have enough PPE and they're amazing. And thank God for them.
So Jack, I realize we have about 9 or 10 minutes left. So I know that you have thought a lot about systems approaches as we are entering now, what is this 3rd surge that I know you've been thinking about a lot. So talk to me about what you're thinking and what has come.
Yeah, so by July, for a small, somewhat paranoid group of us, it seemed increasingly clear that we were not going to have an effective national system that was going to get this under control. And so that by the time it got cold, we were going to do it again. And at the same time, some data emerged that that frankly supported our experience, right? So I had a patient who was a 4th mission patient, right? A humanitarian patient who came in after 11 days, a 40-year-old African-American woman who had been at a small hospital that had said, that had read that advanced ARDS should be pruned. It should be put on her belly, right? And that's true. It absolutely is potentially beneficial. But they'd never done that before because they'd always transferred patients out. And I'm gonna get a little verklempt as I describe this, but when we got her, she had erosions down to the bone on her forehead, on her cheek, and on her mandible, because it turns out putting someone on their belly when they're paralyzed safely for 10 days requires an enormous amount of skill. And sort of one-line summaries in the articles that say proning is valuable don't describe how to do that. And I'd never had to call plastics for a bed sore on a cheek before, where I could actually, she had beautiful dark black skin and you could see the white of the bone through her skin. And the data really bore out that larger volume hospitals, as we've kind of known for 20 years, that are superb at caring for ARDS are in fact superb at caring for ARDS. And that there was a substantial mortality advantage in the 2000s when this data was looked at with rigorous methods. And again, Andy Admin and the group published in JAMA Internal Medicine a piece showing that there was about a tripling of the odds of death if you were at a small hospital, right? A hospital that basically didn't do a lot of ARDS versus hospitals that did. And so a group of us have been engaged in asking the question of how can we make sure these patients don't get abandoned or don't get left at small hospitals, in part inspired by having the privilege of doing the fourth mission at the VA and of seeing the VA say, yeah, our first job is veterans, but actually our first job is Americans. And we're going to help take care of people. And so that resulted in this piece in the New York Times, in part, that as we've been thinking about this, asking the question of how do we think about who's going to get left behind in a system that's not designed to provide superb care, and realizing that it's going to be overwhelmingly folks who are disenfranchised, and particularly Black and Brown lives. And as we've thought so much about this year at the same time about the way Black Lives Matter, saying that, one way strong academic medical centers can say that they value Black lives, as so many as they have, is actually to go save Black lives. And that there are obviously important HR policies that need to be a part of that. But part of it is making sure, if you're a specialized system of excellence, that you reach out to communities of color and you build transfer systems for them to come in. When I'd written this, it was sort of anecdotal. And then since then, the WBEZ and the Wall Street Journal have done some reporting showing that there's compelling evidence in Chicago and LA that the academic medical centers were not doing this. And folks from disenfranchised communities were being left at hospitals that didn't know how to care for them. And so we've had a huge amount of the last few months has been spent on phone calls trying to help academic medical centers say, yeah, you don't want to be an ARDS hospital, and you certainly don't want to be a COVID ARDS hospital, but you're sitting on a multi-billion-dollar endowment and an enormous set of skills. And you can potentially save 1 in 3 to 1 in 10 of the COVID ARDS patients out there if you get them transferred to you versus at a small hospital. So what do we need to do to make that happen? And those have been a set of challenging conversations, because they're trying to get institutions to think differently, from who are their wealthy, well-insured patients who they take care of, to who are the lives that they have this special, unique opportunity to save in this moment of crisis. And in this year where so many Black and Brown people have died, are they willing to step up for it? So yeah, it gets a little moralizing, although it does feel like it's been a long year. And if I've learned nothing else from this year, the sort of moral center of great clinical care during a plague year. And our job, and so much of what's been driving folks is not, has been just trying to do the right thing. And it's been an extraordinary privilege to practice with you, and particularly our nursing and respiratory therapist colleagues who are, and our environmental services colleagues who are just tireless in how far they're willing to go, although they're a little tired. So we've only got about 3 minutes left so we can be respectful of people's time, I guess. Are there any questions folks want to jump in about the sort of policy challenges around making sure people get the best care possible?
I'll ask a question that came in earlier, which I think you both have sort of touched on, but just sort of a more formal research policy question. What role do you see for sort of formal implementation practice or science going forward in the care of COVID patients?
Yes, I think we did, touch on this a little bit
Yeah.
before, but I think there was really this, sort of sense of trying to like redesign some new COVID specific care. But I think that one of the most important things we need to do is these kind of, this ABCDEF bundle is kind of a bundle of, high evidence-based practices in the ICU that, has data, high quality data, 10, 12 years old, really saying that these are life-saving practices. And so we've known that for a long time. And nonetheless, consistently there's data showing that there's barriers, that these are not consistently implemented. It's because they're hard. They're hard in the best of times. And now it's not the best of times. So I do think that there is a role for implementation scientists about how do you sort of implement this in these kind of more challenging situations, or sort of rapidly bring, units and sort of teams up to speed in delivering this kind of team-based ICU care. Absolutely.
And I think, one of the take-home messages is well-supported staff do excellent. Staff who feel like they're not being taken care of by their system find it hard to work hard for their system. And I think we saw over and over again in effort to use magic bullets, either of the EHR or pharmaceutically varied component, and none of them make up for a great ICU nurse.
Definitely. Well, we're down to our last minute. I want to thank you both for taking the time to talk to us. It's been really enlightening. I don't see any other chat questions coming through, so I think we can end for today, but we'll have you back in a few months to talk about your experiences.
Yeah, I mean, stay safe out there, guys.
Yeah.
The next 6 weeks are going to be emotionally devastating, right? They're a
Yeah.
time period where we come together as families, and we just can't. So please think about what you need to do to take care of each other and take care of yourselves. Because I mean, Hallie and I are both really good ICU docs. If you really need us to, we'll stick a tube down your throat, but we'd really rather not for your Thanksgiving. Thanks, everybody.
Yeah, thank you.
Feel free to
Thanks for having us.
much.